Perittalar dislocations. Now these are tricky injuries, not very common, but commonly missed. Now, these are also called as subtalar dislocations, sub peritalar dislocations as well. So it is a dislocation of talocalcaneal joint, but along with the talonavicular joint as well. Uncommon, usually may be missed because sometimes it present in very subtle manner. Types, either it is medial, lateral, anterior or posterior depending on the position of foot in relation to talus. So if foot is medial, it is medial peritalar. If foot is lateral, it is lateral peritalar accordingly. Look at this. This was 28-year male and just fall while walking on footpath, and easily injury would be missed. But look at very classical lateral view. This sinusoidal curve should be maintained. Try to see this. If it is missed, if it is not there, suspect some injury. And see this subtalar facet. And never miss this attitude. Always compare with this. If it is medial peritalar, it looks like club foot. If it is lateral peritalar, it looks like flat foot. Simple. Medial peritalar looks like club foot. Lateral peritalar looks like flat foot. Look at this CT, and then you will come to know that talonavicular joint is almost dislocated. Subtalar joint is dislocated, and this is classical peritalar dislocation. This was reduced, and these are various images. This was stable, so managed on cast only. But post-op, please do the CT scan or correct X-rays to know that reduction is proper. How do we diagnose? I told you, clinically suspect it. If it looks like club foot, suspect medial peritalar. If it looks like flat foot, suspect lateral peritalar. And anterior and posterior may be not very evident clinically. How do we reduce? Suppose it is medial peritalar dislocation. Flex the knee, that will relax gastrocolius. Then give traction to heel, and counter traction is at the knee by assistant. And exaggerate the deformity. If it is medial peritalar, exaggerate in inversion. If it is lateral peritalar, exaggerate in valgus. And then just put your thumb on the head of talus to reduce it. So gently evert in medial peritalar dislocation by putting a thumb on head of the talus. That is how you reduce it, and classical clunk will be heard. Now, see, this is very obvious. This will not be missed, but last case would have been missed. So, see, the foot has moved medially, medial peritalar dislocation, foot medially, CT scan, and this is how it was there. Look at the clinical presentation, and this can be reduced well in emergency department, in casualty. Same maneuver, flex the knee, relax gastrocolius, longitudinal traction, and this can be reduced. Medial is common. Urgent reduction even in ER can be done, and they are usually low energy injuries with good outcome. Arthritis is more common than AVN. Now look at this. She is a 70-year lady, fall from height of about 2 to 3 feet. She was standing on a chair and she fell down from that. Again, easy injury to miss. See this, very subtle talonavicular subluxation and subtalar as well. Okay, so don't miss it. CT scan was done. See this, subtalar is totally dislocated. Looks quite innocent, but has significant this thing. Now see, it looks like flat foot because it is lateral peritalar, and this is how it was reduced intra-op. Why? Because these tendons were interposing. So by protocol, first close reduction maneuver in ER, If not possible, close reduction maneuver in OR. If not possible, open reduction. Got it? So this is how then subtalar and talonavicular joints were fixed with K wires, and then the peripheral talar fracture was managed. So lateral peritalar is less common than medial. It is little high energy injury associated with some fractures and has arthritis more common than medial one. This is an algorithm we will discuss. If this is peritalar dislocation closed, try to do close reduction in ER. If it is possible, post-op try to do CT scan to see the reduction. And if it is stable, put on the cast. If unstable, put on the K wire. If reduction is not possible in ER, try to do close reduction in theatre. Not possible, then do open reduction and K wire. Open injuries are also possible. Try to do it by the merit of any open injury. Like this. This was a open fracture dislocated from ankle talonavicular joint. Debridement, reduction, simple K wire fixation was done, and this is how he went on to heal. Almost we have more than 10-15 years of follow-up now, and this is his function, which was totally extruded fracture, and we have published it also. What are poor prognostic factors? Open injuries, associated fractures, and lateral peritalar has got worse prognosis than medial. So to summarize, peritalar dislocations are either medial, lateral, anterior or posterior. Try to identify them, don't miss them, and try to do reduction in ER. It is so many times possible. If not possible, close reduction in the operation theatre. If not possible, be ready for open reduction. CT scan is indicated post-op to see the reduction quality, and failure to do reduction, try to do open reduction as early as possible. Thank you so much.